So I am Qianyi from the University of Illinois at Urbana-Champaign. Along with my co-author, Professor Ya-Cheng Qi, we are honored to present our research paper, and our working title is Time Dimension of the Link Between Income Inequality and Health, the cumulative, the immediate, cumulative, and comparative effect. So this work is theoretically motivated by the long-lasting debate about the contextual effect of income inequality proposed originally by Wilkinson. Wilkinson's income inequality hypothesis was originally was meant to explain the link from income inequality to health for population that has already gone through the epidemiological transition, where absolute material conditions are no longer determinative to individual health. In contrast, the IIH proposed that income inequality universally impairs individual health in a society for every members by triggering the psychological and social risk and chronic disease. However, the IIH was then challenged by the absolute income hypothesis proposed by Greville in 1998. So the AIH argues that income inequality per se have no direct impacts on individual health. Instead, the observed statistical correlation between those two variables are actually confounded by the individual absolute income. There is another alternative explanation toward this link, which is called the neo-materialism pathway. So the neo-materialism pathway argues that income inequality correlates with individual health only because they are both outcomes of the cultural norms, social regimes, and political ideologies. So in sum, the absolute income hypothesis and neo-materialism pathway all assume that the income inequality itself did not have any impact on individual health. Even decades after those hypotheses were originally proposed, there are still very inconsistent empirical evidence, and those evidence are usually largely based on, heavily depends on the levels of units of analysis, study periods, or the study regions that scholars choose. Therefore, the central research question remains largely unsolved, and this is also our research question today. So, does income inequality on the country level adversely affect individual health regardless of individual social economic backgrounds? That is in line with the prediction of income inequality hypothesis. To answer this research question, we propose the temporal structure of IIH to better explore the complexity of the income inequality to health link. And here are three different rationales for the temporal structure we proposed here. So first, we identified from the current literature of the fluctuating nature of the income distribution, especially since the 1980s or the so-called neoliberal era. Therefore, we propose that the wild fluctuation of income inequality change the reliability of short-term points of specific measures of income inequality, such as the instant Gini index, which is widely adopted in the current literature in the exploration of individual health. The second point is that the psychological mechanisms proposed in the IIH previously of physical health usually followed the latency period or time lagging effect. And we advocate that exploring period-long income inequality or a cumulative measure would be more suitable for those observed time lagging effects. And the third point would come from the inspiration of psychology theory, especially the prospect theory. We find it very interesting. This theory argues that individuals perceive external stimuli in comparison with historical reference points. Therefore, we need to consider the possibility that longitudinal change in income inequality could have a more substantial impact than the inequality itself, which necessitates comparative measurements of the dynamic trends. So accordingly, based on the temporal structure we set up here, we innovate for 3 different indicators on the measures of income inequality, namely the immediate, comparative, and cumulative indicators. So the immediate Gini index would be very straightforward. It refers to the Gini index used collected in the survey year, and that is the most frequently used indicators in the current research. We also introduced the comparative Gini that is referred to the numeric gap between the Gini index of the survey year and that of 10-year prior to the survey year. So basically, is the differences between 2 point-specific measures. And finally, we introduced the cumulative Gini, and that equals to the average number of all Gini index from the 10 years period prior to the survey year. And this is the period-long measures. And the immediate, comparative, and cumulative Gini are what we use for as our independent variables in this research. So just to give you a quick ideas of our research design, our data source is very diverse. In our micro level data set come from the World Value Survey, a repeated cross-sectional data set, and we choose the year from 1981 to 2016. We also have a lot of different indicators on the national level, and those variables come from the standardized World Income Inequality Database, the World Income Inequality Database, and the Health Indicator Dataset. Our analytical samples are covering more than 31,000 individuals, 3 million and 3 millions and 31. That is more than 310,000 of individuals from 91 countries or regions across the world from more than 27 years. Also, I want to highlight here the analytical samples come from all 4 groups of the national development stage, ranging from the higher income countries to the lower income countries. But our samples, the geographic representation of our samples would also affect some of our conclusion, and you will be able to see how that representation would affect our by groups analysis later. So here are our variables. As we mentioned before, the independent variables are 3 different indicators for the Gini index. The dependent variables is the subjective health reported and rated by the respondents themselves, ranging from level 1 to level 5. So the level 1 is very poor health, and the level 5 is very good. Our methods is the multi-level panel data methods, that is according to our data structure, and we utilize 2-level random effect model and a 3-level fixed effect model. And we will show how the model selection affects our conclusion later also. But for both 2 models, we set up the individual level on the lowest level and the country time level as the second level. And we also have some control variables both on the individual level and the national time level. So here are our preliminary model results. So first, we want to show you the predictive value for health given the immediate measurements of Gini index. And we break down our analysis here by 4 different national income groups. And as you can see, the positive link between the immediate income inequality to individual health is very evident for all regions across the world. And this actually means as the income inequality get more severe, then the individual health is actually become better. which is totally contrary to the income inequality hypothesis, and it is somewhat confusing here. I also want to draw your attention to the visible regional differences here. So as you can see, even though the immediate Gini index might change the health level, but for higher income country, it is always, the respondents are always reporting a better health no matter of the income distribution condition. While the other three groups, including the higher middle income countries, lower middle income countries, and lower income countries, they always stay at a lower level in terms of their health. And the second figure shows us a different measure, the data results from a different measure, that is the cumulative Gini effect. And as you can recall, this is the average effect of all income distribution from the prior 10 years. This time we choose a little bit different visualization method. So this figure shows us the coefficient estimates instead of the predicted value here. And as you can see, for those here, we present both the model results from the random effect model and the fixed effect model. And this time we show data results from both the globe, so the entire sample, and three different income regions, because we combine the lower middle income groups with the higher, with the lower income groups, considering the sample size issue here. And one conclusion we can draw from this figure is the random effect model actually did not provide the same results as the fixed effect model. So fixed effect model usually have less significant and less positive coefficient estimates. And this is the first conclusion. And the second conclusion is, even though there might be differences between model, but the results still remains very similar to what we can observe from the immediate effect. That is, we can still observe a positive link from income inequality to individual health, which means when income polarization, income distribution get more polarized, then individuals' health is still suffering. And this draw us to conduct the last set of the analysis that is based on the comparative Gini index. And I want to remind you here, the comparative Gini index actually means if the comparative Gini index is positive, it means a society is getting more and more unequal in terms of the income distribution. Therefore, when we interpret this results, then things change a lot in terms of the conclusion. So as you can see, the coefficient estimates this time usually falls below 0, and they usually remains largely statistically significant. The negative coefficients here means as the income distribution gets more polarized, then health for all members from that nation would universally become worse. So their health level goes down. This aligned with what the original income inequality hypothesis predicts, even though we are proposing in the comparative version, but they are proposing in the immediate version. Just to give you some concluding remarks before we leave, our data suggests that the comparative or dynamic effect of income inequality varies significantly from the static, or we call it immediate and cumulative effect. Thus, we emphasize the importance of temporal structures of the income inequality to help link. Second, our finding asserts that income inequality negatively impacts individual health universally, aligned with the income inequality hypothesis, but we argue that in the comparative version, and this reinforces the consensus among all demographers and population scientists that health is not solely biologically determined, but is also shaped by societal constructs. And finally, The perplexing positive correlation between income inequality and health demands careful interpretation in future research, and we call for more detailed and better quality data and better motivated methodology. And this is our presentation, and thank you so much for listening.